Okay, hello everyone. I will present the comparative study, tubular decompression versus UBE decompression for the treatment of lumbar spinal stenosis. For a little introduction, we know that mini invasive technique like unilateral laminectomy by bilateral decompression have become the standard in the treatment of the lumbar spinal stenosis. Recently, UBE technique has been introduced with early promising results. However, most studies compare tubular decompression with monoportal decompression. A few have analyzed the radiological outcome specifically. This was a retrospective single-center study performed by one surgeon. Patient underwent either tubular decompression or UBE decompression. But it's important to mention that UBE decompression were performed during the during the early surgeon experience with this technique. Patient MRI and clinical outcome were evaluated at 3 months postoperatively. Radiological measurements were performed by a blinded surgeon. We compare the preoperative MRI and postoperative MRI. We performed 2 types of measurement: the anterior-posterior canal diameter in millimeter and the canal surface area in a square millimeter. We included patients with moderate or severe lumbar spinal stenosis, grade C or D, according to SHISA's classification. Patients were excluded if they were under 50 years old, lacked MRI, previous surgery in the same level, presence of macro instability requiring fusion surgery. A total of 103 patients was included, 52 patients in the tubular group and 51 patients in the UBE groups. There were no significant difference between groups constituting 2 homogeneous groups. There were no significant difference in age, weight, anticoagulant therapy, but there was a tendency of the left side approach in the UBE groups. For the ODI or lumbar VIS or radicular VIS, there were no significant difference. Similarly, there were no significant difference in the preoperative radiological finding, including the presence of spondylolisthesis or and degree of stenosis. For the radiological results, we can see UBE provide a better decompression with the increase in the anterior-posterior diameter and the increase in the canal surface area is better with UBE decompression. But if we analyze it using the SHISA classification, there were no significant difference. For the clinical results, ODI or lumbar VIS or radicular VIS improved similarly in both groups. For the operative time by level, no significant difference. For the time of hospitalization is similar, but UBE decompression was associated with the presence of hematoma, higher rate of hematoma in the postoperatively MRI, also not always requiring surgical revision. No significant difference was found for the overall of reoperating surgery. In conclusion, both tubular and UBE decompression are effective in the treatment of lumbar spinal stenosis. UBE provides a superior radiological decompression, even during early surgeon experience with this technique. But this superiority in image cannot be translated in a better clinical outcome. UBE decompression was associated with the presence of hematoma, but not necessarily needing a revision surgery. Thank you very much.
So thank you for sticking all the time. Also, very nice presentation. Have you studied if the decompression of you studied the decompression of the central canal? I mean.
Yes, we use in the Shisa classification the anterior-posterior diameter and the canal surface area. We use in the ocelix.
Yeah, because I have the feeling that what gives us the biportal endoscopy gives us is the better visualization, especially in the contralateral side. When with the tubular surgery, you struggle a little bit to know how far you are. So I think it's one of the benefits, and maybe if studying just this part also could be like a big difference between both.
But maybe is that the reason? But the principal point I think is all UBE decompression were performed in the first patient with this technique, and we have a clinical outcome similar or better in comparison with tubular decompression. So I think that is important.
Yeah, of course. Of course.
Very nice presentation too. In terms of the hematoma, you put drains in all patients or no?
I think
you don't put drains.
No, this is my 51st cases, and at that time I don't put some drain, but then I moved to drain, and I've less.
And have you compared the
yet.
MRI post-op with the drain?
No, but because the MRI is at 3 months, there is no more hematoma at that time. But because for this patient, there's some pain, and we do a new MRI at maybe 10 days, 15 days, it depends. But if the patient have no pain, I don't do a new MRI at 15 days.
Yes, because I think it would be interesting because it has an hematoma. We put a drain to decrease the hematoma, but we don't know if a drain decreases the incidence of an hematoma. We see that in other things, primarily in orthopedics, hip arthroplasty, knee arthroplasty. Most of the that are surgeries that bleed much more, and the biggest centers are starting to not use drains because they conclude that it doesn't decrease the incidence of hematoma. That accumulation of blood happens anyway. So it's something interesting to study next time.
If you want, I invite you to come this afternoon because I make this study and he'll show you the results. Yeah, thank you.